Welcome, everybody. We are going to get started very shortly with our AMSSM Fellows Online Education session, and I'm very pleased to welcome Adam Ridley to provide us with a board review for this week. That's pretty timely, with many of you anticipating sitting your boards in the next month. So this is something that we do weekly in the New England area in a collaboration of fellowships. Um, I'm Hamish Kerr, by the way. I'm one of the fellowship directors in the area, and Adam was a recent fellow at UMass. He actually did his medical school and family medicine residency at the University of South Carolina, but he has remained at UMass to start his faculty practice, and is especially interested in diagnostic and procedural ultrasound and obesity medicine. So he's going to be giving us some questions today. There will be opportunity for answering those with the polls. Andy Myers behind the scene doing that for us. As always, try and keep your mics muted, and we do want participation. And if you want to add comments into the chat or questions, I will try and field those during the presentation. And I think, for the most part, that's all we need to say before we get started. So Adam, the floor is yours, and looking forward to your talk.
Great. Well, thank you, Hamish. I appreciate the introduction. And congratulations, everyone if you're watching this usually means you're wrapping up fellowship year, and it can be a long year. So congratulations and good luck on the CAQ. So today I am going to try to present 16 questions, and they all are centered around some sort of radiographic interpretation. I tried to go back to look at some of the old CAQ reviews that were done to try to see if I could pick up on a theme that maybe hadn't been touched upon as much, so that you have more resources to go back to and utilize. I tried to center this talk all around different sort of radiographic interpretations. And the reason for that, I think, is an important one. So for the CAQ, you will be asked to interpret images, and that leads to you ultimately asking answering a variety of questions. Some first order questions like, what is this? And then most frequently second order questions like, what should you do with this, without them necessarily telling you what the actual radiograph or image shows you. All the questions that I'm going to present today, they're from the AMSSM Sports Medicine CAQ study guides, specifically the 5th and 6th editions. And I do have a disclaimer. I did modify some of those questions. I did add a couple of different images to either make the question more challenging or make the image a little bit more clear in terms of its presentation. And I did remove some of the wording from some of the questions, again, just to try to make it a little bit more challenging. If you've already gone through the CAQ review books, try to make this something that, if you can get these questions, the questions on the exam itself should be easier. So we'll go ahead and get started. This is question number 1. So a 13-year-old female softball athlete was sliding into third base and got her ankle twisted underneath her body. There was immediate pain and swelling. She was unable to weight bear. She locates the pain primarily over the medial ankle. You obtain x-rays which show the ankle fracture. Which Salter-Harris classification best describes her ankle fracture? So the answer is D. So Salter-Harris 4 fracture. And what you can see here on the image is extension of the fracture above and below the physes. So if we look at the Salter-Harris classification, this is something that you will be tested on. You can use the mnemonic Salter as a way to remember. So S representing straight across or right through the physes, A, Salter-Harris 2, representing a fracture through the physes with extension towards the diaphysis, so above. And then 3 is L, lower, so into the epiphysis. T through, so this would be our Salter-Harris 4, that's through the physes itself, above and below. And then a 5 is collapse of the physes. So question number 2. A 13-year-old overweight boy presents to clinic with right knee pain that started about 3 weeks ago. He started to limp because the pain was because of the pain about 10 days ago. He denies injury and says his day usually consists of playing video games. His knee exam is unremarkable. What is the next step? A, CBC and ESR. B, AP, lateral and sunrise x-ray of the right knee. C, MRI without contrast of the right hip. D, AP and frog leg x-rays of his hips. Perfect. Nicely done, everyone. So the answer is AP and frog leg x-rays of his hips. So this question, we're going to go right into a third question here. The additional portion of that is x-rays of the hip is shown below. What is the next step in treatment? Is it A, rest, ice, elevate the leg? B, urgent referral to orthopedic surgery? C, partial weight bearing on crutches? D, weight bearing is tolerated and reevaluate in 6 weeks. Perfect. You guys are doing great. So the answer is B, urgent referral to orthopedic surgery. And so I think you're all recognizing what this is, but this is slip capital femoral epiphysis. This is in that growth plate in the femoral neck. It's something that typically requires evaluation of the with x-rays of both hips for the comparison views. Typically, these patients are immediately made non-weight bearing, and early surgical stabilization of the femoral head is essential. It is interesting to note that 20 to 40% of cases have been reported as being in bilateral hips. And the other important thing to recognize, which it seems like you all have done, is that hip pain in an adolescent patient can be referred to the knee. So in the setting of a normal knee exam, in this particular case, you can feel confident that the next move would be to get x-rays of the hip and then move on to treatment for the SCFE. So question number 4. A 42-year-old female presents to your sports injury clinic 2 days after a fall off her horse. She was riding in a local polo game and accidentally was thrown off the horse. She landed on her right hand and rolled to her side. She has moderate pain along her lateral right elbow and is unable to flex and extend it fully. She has been icing it, taking Tylenol, and resting. She's concerned about the pain and swelling. She has no extension to 100 degrees of flexion. She has pain with right hand supination along the lateral elbow. She has evidence of an elbow effusion. Her neurovascular exam is normal. After reviewing the x-rays, what do you tell her? So her x-rays are to the right. She has a radial head, she has a radial head fracture and needs to be placed in a long arm cast for 4 weeks prior to beginning therapy. B, she has an elbow radial collateral ligament sprain and needs to use a sling for 2 weeks. C, she requires an MRI and should be placed in a hinged elbow brace until it is reviewed. D, she has a radial head fracture and needs to use a sling for 5 to 7 days and start early mobilization. Nicely done. So the answer is D. So she does have a radial head fracture. So radial head and neck fractures. So the mechanism typically is a fallen outstretched hand, and it's axial loading through that radial head and neck, usually up against the capitellum. Non-displaced fractures are frequently difficult to identify on radiographs. So you're looking for secondary signs of potential injuries. Tenderness over the radial head with an elbow effusion, which can be seen on this x-ray here with the Sale sign and can be seen on the original x-ray, is a sign that there is an effusion in the joint, and you should be looking for and trying to rule out the possibility of a radial head or neck fracture. If you look at the picture, what you're looking at on the bottom picture is the red represents the effusion can be hemarthrosis, which pushes the anterior fat pad upwards and creates a sail effect. So less of an opacity in that area and creates this triangular structure that we frequently describe as the sail sign. So patients with these injuries should be given a sling for comfort with early range of motion to try to prevent any sort of elbow stiffness, which is frequently a consequence of these injuries. Try to get them back into full extension as best we can and as soon as we can. Question number 5. A 21-year-old male presents with a complaint of right wrist pain and weakness. He jammed his right wrist playing pickup basketball. He fell and landed backwards on his right hand. He went to a student health center later in the week when the wrist was still swollen and painful. He reports an x-ray showed no broken bones and that he was diagnosed with a sprain. He was given a soft brace for comfort. The wrist bothers him on and off over the past 6 months and never fully healed. He has gradual increase in pain and decreased strength and function. He has pain with a forceful grip with the right hand. X-rays are shown below. Which one of the following statements is accurate regarding his injury? A positive Watson test, also known as scaphoid shift test, must be present to make this diagnosis. B, scaphoid bone is gradually displaced by a chronic pull of the muscles and tendons that insert on it. C, the instability of the injury is associated with dorsiflexion of the lunate bone relative to the distal carpal bones on lateral radiographs. Or D, the finding is always associated with a non-healing occult fracture. So the answer is C, and we'll move on to the explanation here. So scapholunate dissociation, so the mechanism here is a fall back. Usually it tends to be a fall backwards on an outstretched hand with the hand and wrist in an extended position. This is an injury that frequently gets missed initially and oftentimes gets diagnosed as a wrist sprain that just doesn't seem to heal. People can go months with even worsening pain until this is re-imaged or reassessed and found. Usually what you're looking for is displacement between the scaphoid and the lunate. Anything more than 3 millimeters of widening between the scaphoid and the lunate on the AP suggests the potential injury to the ligamentous structures in that area. The loss of stability secondary to ligamentous disruption oftentimes leads to that dorsiflexion of the lunate relative to the distal carpal row. There's a test, the Watson test, the scaphoid shift test. It is somewhat of a challenging maneuver to do, and therefore it does have some poor sensitivity and I should say specificity there. An acute non-displaced and a chronic asymptomatic case can be treated non-surgically. Otherwise, these injuries are frequently treated surgically to prevent scapholunate advanced collapse, so that slack wrist, which all that means is that capitate, which is sitting just above that scapholunate association there, that capitate wants to start dropping down, and it can lead to more and more arthritis between the carpal bones, but frequently in the radiocarpal joints as well.
Question in the chat, Adam.
Yes.
Is the injury better seen on X-ray with a clenched fist?
You can get it better with a clenched fist. If you put more stress over that area, you can load those structures. It oftentimes is missed, so you can play around with it. It is seen without having to do a clenched fist as well, though. But anything more than 3 millimeters is still what you're looking for in either case. So question number 6. So a patient comes into your office with complaints of left foot pain. She is a 25-year-old avid runner training for a marathon. She's a vegan and has an irregular menstrual cycle with BMI of 19, but is otherwise healthy, without any history of prior musculoskeletal injuries. She has pain and tenderness along the plantar aspect of the foot along the sesamoids. She has already tried 1 month break from running in stiff-soled shoe for 1 month based on the recommendations of a friend. X-rays are obtained in the office and are shown below. What is your next step in treatment? A, you diagnose her with a sesamoid stress fracture, recommend 3 to 6 weeks of non-weight bearing and a cam boot. B, you diagnose her with a sesamoid stress fracture and recommend she see a surgeon to discuss sesamoid resection. C, you diagnose her with a bipartite sesamoid and provide her reassurance. Or D, you are still concerned she has sesamoid stress fracture and order an MRI scan to confirm. So the answer is D. You're still concerned she has a sesamoid stress fracture and order an MRI scan to confirm. So we're going to talk about this one. I thought this one might trip people up a little bit. And I put a little asterisk here. So I did sort of modify this question to make it more of a point to really have you guys look at the x-rays. So the original question did indicate concern for stress fracture in the sesamoid. The image on the right here is actually an image of a bipartite sesamoid. And the way you can sort of, it can be challenging sometimes, but oftentimes bipartite sesamoids have very classic sort of pattern where they have a pretty clear, smooth separation between the two parts of the bipartite sesamoid. Smooth edges, even edges. They tend to be a little bit larger. Whereas a fracture through that area can be a little bit more irregular, especially through the potential fracture line. Bipartite sesamoids do, they're just as at risk for a stress fracture as any other sesamoid bone. What's interesting in this prompt is the way that they hinted towards an energy deficiency in this patient. So again, I think everyone's sort of on the mark in terms of thinking about the stress fracture. But the question goes to the point that this patient has tried rest and boot, and the x-rays are not, they don't confirm stress fracture or rule out stress fracture. So at this point, you're going to have to move on to looking into additional imaging to rule out the possibility of that stress fracture in that sesamoid. Question number 7. A 21-year-old college soccer player injured his right knee in a hyperextension injury and does not recall hearing a pop, click, or a snap. He had difficulty with weight bearing and an effusion was present. X-rays were obtained, and you can see below. Injury to what ligament is most likely? A, medial collateral ligament, B, posterior cruciate ligament, C, lateral collateral ligament, D, anterior cruciate ligament, or E, iliotibial band. Awesome, nicely done. So the answer is D, so anterior cruciate ligament. So what are we looking at here? This is a Sagan fracture. So I'll go back to the image. So you can see over that lateral aspect of the tibial plateau. It's technically over the anterior lateral aspect of the tibial plateau. Is a classic fracture pattern frequently seen in ACL injuries. So this is an avulsion fracture of the anterior lateral tibial plateau. And there's several people describe the location of this fracture in several different ways, but frequently described as the location where the lateral capsular ligaments attach, which is just posterior to where the IT band inserts over Gertie's tubercle. So that is a frequently really pathognomonic for ACL injuries. So when you see that, you really have to be thinking along those lines. Question number 8. So a 19-year-old collegiate female cross-country runner presents with 2 weeks of worsening right anterior groin pain 1 month into her fall season. This pain worsens with running. It would previously resolve within several hours of completing a training session and with oral ibuprofen, but now persists at a low baseline level and is increasing with weight bearing. Pain now wakes her from sleep. There was no traumatic mechanism of onset or associated bruising, mass, or swelling. X-rays are as seen below. What is the next step in management? Is it A, referral to orthopedic surgery for percutaneous screw fixation of the femoral neck to stabilize and prevent progression? B, institute strict non-weight bearing status with axillary crutches and remove from training and competition? C, referral to a hip surgeon for evaluation for femoroplasty and acetabular labral repair? Or D, allow her to weight bear as tolerated and initiate body weight alleviated treadmill protocol? Great. So the answer is B. So institute strict non-weight bearing status with axillary crutches and remove from training and competition. So this is talking about a femoral neck stress fracture. And there's really two types of femoral neck stress fractures. We classify them as either compression type stress fracture, which is on the inferior portion of the femoral neck, inferior medial portion of the femoral neck, versus a tension-sided femoral neck stress fracture, which is over the superior lateral aspect of the femoral neck. So the compression-sided femoral neck stress fractures have lower risk of non-union versus the tension-sided femoral neck stress fractures are at much higher risk of non-union. So they're treated differently. This case represents a compression-sided femoral neck stress fracture, which can be treated non-surgically. And that non-surgical treatment is usually non-weight bearing with progressive weight bearing once pain-free. Those tension-sided stress fractures frequently get treated with percutaneous screw fixation, given their higher risk of non-union. Question number 9. While participating in sideline care of a collegiate football game, you were called to care for a player who remained on the ground after a hard tackle. You observe a 22-year-old man lying supine in obvious respiratory stress, but able to speak and complete sentences. He is complaining of right-sided chest wall pain and difficulty breathing. You can move him to the sideline and remove his helmet and pads. Soon after, he complains over worsening dyspnea and lightheadedness. On pulmonary auscultation, you note decreased breath sounds on the right and subcutaneous emphysema. His trachea is deviated markedly to the left. What is the next course of action? Is it A, support the patient's breathing by keeping his head in the sniffing position? B, insert bilateral nasopharyngeal airways? C, insert a right-sided chest tube at the mid-axillary 5th intercostal rib space? D, insert 12 to 14 gauge angiocatheter at the patient's right mid-clavicular line at the 2nd intercostal space. Great. Yeah, this is a good conversation to be had here. So the answer is D. So insert a 12 to 14 gauge angiocatheter at the patient's right mid-clavicular line in the 2nd intercostal space. So on the right here, we have a picture of a tension pneumothorax, which was described in the prompt. So this one didn't have an X-ray to start, as it was this clinical scenario was on the sidelines of a football game, which is pertinent to the answer here. So in the setting of so whoever answered C, right-sided chest tube at the mid-axillary 5th intercostal rib space, that's not wrong from the standpoint of treatment, but it would be something that chest tube placement is typically done in a sterile fashion and would be done as a more definitive treatment in a hospital setting. Whereas in the sidelines, an angiocatheter placement is the preferred technique. And so this question also gets to the question of where do you put that needle or that angiocatheter to decompress the thoracic cavity. And we can talk about that in a little bit here, but just to go through tension pneumothorax. So the injury, what happens in a tension pneumothorax is there's an injury to the lung that creates a one-way valve and allows air to accumulate in the thoracic cavity in that pleural space. That air accumulation can cause deviation of the thoracic organs to the contralateral side and can happen fairly quickly as air accumulates. This can lead to vascular compression and decreased preload to the heart and rapid deterioration. So this is something that needs to be treated very quickly, especially when the prompt starts describing that tracheal deviation. So needle decompression is needed to release the air. So if we go back again, so the placement of the needle is important. So traditionally it's taught in the answer D here to put it in the mid-clavicular line at the 2nd intercostal space. However, there's a caveat to that. So any individual with pectoral development, significant muscle tissue over the pectoral region, it may be very challenging to get a needle into the pleural space through the pleura to actually do that needle decompression. So what you should be aware of is that the alternative option, which can still be done with a 12 to 14 gauge angiocatheter, would be that mid-axillary fifth intercostal rib space, which would be a place to avoid some of the muscular tissue that could limit the depth at which your needle could penetrate.
Adam, just to shout out to Andy Getson, who did a sports pulmonology lecture last week, and some of the participants tonight are referencing that, which I think is excellent repetition. And obviously, pneumothorax is one of those conditions that we don't always think about. So good to be hit on 2 weeks in a row.
Great. Glad. I hope I said the same thing. All right, so question number 10. So a 36-year-old female rock climber presents with neck pain that began abruptly while performing a difficult move 5 days ago. She denies radicular symptoms. She is tender over the lower cervical spine with a normal neurologic exam to both upper extremities. Her cervical spine x-rays are below. What is the appropriate next step in management of this injury? Is it A, place the patient in a C-collar, lay flat, and call EMS to transport to the ED for neurosurgical consultation and further assessment? B, provide collar for comfort, pain control, and rest from climbing or other strenuous upper extremity activities until follow-up? C, refer to physical therapy and allow activities as tolerated? Or D, obtain flexion extension views to assess for instability, followed by MRI if abnormal or equivocal? Great. So this is a good one to talk about. Not something you see all that often, but the answer is provide collar for comfort, pain control, and rest from climbing or other strenuous upper extremity activities until follow-up. So this is what we're looking at here is a C6 spinous process fracture. Has the name, we frequently call these Clay-Shevler's fracture, but I've highlighted it here on the x-ray. So you can see on the lateral view of the cervical spine, that fracture to that spinous process. These are very stable fractures, and so they typically heal on their own with relative rest. It's not something that typically needs any sort of surgery. So mainly what you're doing is shutting them down from additional injury to that particular area and letting the bone heal. Once when your guiding light is going to be pain in that general area. Once the pain has resolved, then you can have them start returning to activities as tolerated. One caveat to that is, or one thing to be aware of is that these can be pretty painful, and the pain can linger quite some time. So the expectation that you might want to set for your patients if you end up coming across this is, letting them know, hey, this may take several months, 3 or 4 months for the pain to subside. So just something to give them, set them up with those expectations. So question number 11. So this is a 12-year-old male presents after hearing and feeling a pop at the medial elbow while pitching. He has increased laxity to the valgus stress testing of the elbow. X-rays are seen below. What is the diagnosis? Is it A, effort thrombosis, B, medial epicondylar avulsion fracture, C, ulnar collateral ligament injury, D, valgus extension overload syndrome? Great. So we'll chat a little bit about this. So this injury is a medial epicondylar avulsion fracture, and it's worth talking about this a little bit more because of other types of injuries to this area. So a medial epicondylar avulsion fracture is typically seen in a skeletally immature patient with the same mechanism that would frequently cause UCL tears in a skeletally mature patient. So what we know about those patients, and I know you guys know this, but the skeletally immature patient, those ligamentous structures tend to be stronger than the bone, and can frequently cause bony injuries like avulsion fractures when strained or acutely loaded. One thing to be sort of comparing this to is that medial epicondylar apophysitis or little league elbow, which is different. So it's a different sort of presentation and different sort of pathology, though still affecting the same sort of structure. So whereas little league elbow is a chronic overuse injury that causes inflammation in the physes and can cause some widening there, it's something that is developed over over longer periods of time, usually in throwing athletes, and leads to progressive pain over time. Whereas this patient had a sudden sort of mechanism to their injury with displacement of the medial epicondyle at that growth plate. So this is for these types of injuries, these minimally displaced fractures can be treated in a cast for 4 to 6 weeks. But with some displacement, frequently these are treated with screw fixation, especially if someone's trying to expedite return to throwing. But again, these are good ones to know about. We see these types of injuries throughout the year, but especially during throwing seasons, and something to be aware of, especially when comparing to Little League elbow. Question number 12. So which of the following is considered a high-risk stress fracture that warrants especially close follow-up due to its increased risk of non-union and potential for surgical treatment? Is it A, the distal fibula, B, the inferior aspect of the femoral neck, C, the anterior cortex of the tibia, or D, the midshaft of the third metatarsal? Awesome. So good. Another good one to talk about. So the anterior cortex of the tibia is the answer to this one. So just in comparison to the others listed here. So the complete list here just wrote out sort of some of the high risk stress fractures and put one of the examples on the side here. So to go through each of them. So the superior femoral neck, tension sided stress fractures. So we've already talked about that one. I just wanted to put that right at the top since we've already discussed that. The patella, the anterior tibia, so the anterior cortex of the tibia specifically is at higher risk. Same sort of idea. There's different sides of each cortex. Will experience different sort of loading patterns, and the anterior cortex of the tibia in particular is vulnerable. The medial malleolus, the talus, the tarsal navicular bone, the proximal fifth metatarsal, which I've put here on the right, stress fracture of the proximal fifth metatarsal, as well as great toe sesamoids, which we've also discussed frequently require that MRI scan or other imaging if unsure, especially if someone has presenting with what appears to be bipartite sesamoid. Still, again, concerning. We want to make sure we would fully evaluate for those types of injuries. So question number 13. A middle school soccer player presents to the emergency department with a knee injury from a collision with another player. The mechanism of injury is unclear. There's a large effusion. The knee is diffusely tender on examination. Based on the MRI findings presented in the image, this soccer player most likely suffered which of the following? Is it A, a quadriceps contusion, B, transient patellar dislocation, C, complete ACL rupture, or D, medial meniscus tear? So the answer for this one is a transient patellar dislocation. So we'll talk about it a little bit here. So this is also this is a matter of understanding anatomy, also understanding what an MRI can tell you. So we'll focus on the MRI image here for a second. So to orient ourselves, we're looking at an axial T2 image here of the knee. What we can see over the top here is the patella. In these T2 images, you have to remember that edema or fluid will show up bright in a T2 MRI image. So the effusion in this knee is showing up as bright white. And then if we're looking at the bony structures themselves, so if we're looking at the femoral condyles down here, as well as the patella up here in the patellofemoral groove here, you can see that the patella has a portion of it that is brighter than the rest, and that suggests potential edema, maybe bony contusion. And you can find a similar sort of contusion over the lateral femoral condyle seen here in the image. So what's happening here is reciprocal contusions, so Cushing contusions, which we can see in different types of injuries. Most commonly, we think about them in the setting of patellar dislocations like we're describing here, but also can be seen frequently in ACL injuries, affecting the posterior aspect of the tibial plateau and femoral condyle. So here, if we go back to the patellar dislocation, so again, this is a reciprocal contusion that we were describing there on the image, kissing contusion, and can be seen in that T2 weighted MRI imaging, secondary to the bony edema. The majority of patellar dislocations occur as lateral dislocations, so the patella moves lateral. And this can cause different injury patterns, frequently, again, causing the bony contusion, but it can also cause different injuries like OCD lesions, so injury to the cartilage in the knee, the undersurface of the patella, can lead to avulsion fractures, and frequently lead to tears of the medial patellofemoral ligament. So this is showing some of those injuries there. Typically, initial injuries are treated non-surgically with patella stabilization brace, some activity modification, and a rehabilitation protocol. If you have any of these other sort of complicating injuries, sometimes these patients will go to surgery, but frequently, if these injuries recur over and over again, they are oftentimes treated surgically to help stabilize the patella and try to prevent recurrence, mostly to prevent those complications of recurring patella dislocations. So question number 14, an 11-year-old male comes to your office with left knee pain. He reports that 2 days ago, he was playing soccer and kicked a ball simultaneously with another player and felt an immediate sharp pain in his ankle. He was unable to continue play. He has had significant pain and limp since the injury. He's never had any knee pain in the past. Examination shows an extension lag and tenderness of the inferior pole of the patella. Knee radiographs are seen below. What is the most likely diagnosis? A, patellar sleeve avulsion fracture. B, Sinding-Larsen-Johansson disease. C, Osgood-Schlatter disease. Or D, tibial tubercle avulsion fracture. Awesome. Nicely done. So the answer is A. So we'll take a second. We'll focus in on this X-ray for a second. So to get everyone oriented, so we're looking at a lateral X-ray of a knee. We're focusing in on that inferior pole of the patella, and so the basically origin of that patella tendon, you can see an irregularity to that inferior pole, and these can look pretty benign, and that's there. Unfortunately, they can appear very benign on X-ray, but actually be fairly significant injuries. This is worth talking about because it can be confused with other types of problems. So similar to some of the things we've talked about today, it's one of those ones that you need to know about. I will tell you a personal story that one of my first couple of days as an attending, a patient came in with almost exactly this description. And sure enough was a patellar sleeve avulsion fracture. And it's pretty profound to look at the X-rays, and it was barely anything on the X-ray, but the exam was pretty significant. These patellar sleeve avulsion fractures, they represent an avulsion fracture from the distal pole of the patella and frequently involve the chondral surface of the patella. So I love this image on the right because it sort of gives you a sense of what we're dealing with here. So there's this disruption of the patella tendon itself, but it takes off a portion, basically some of the chondral surface in the overlying surface of the patella, and can lead to those OCD type lesions underneath the patella. Again, they're frequently subtle or benign appearance on X-ray and underrepresent sort of the severity of the injury sometimes. The exam shows extensor lag or complete extensor failure. So when you do some sort of test strength in extension, but a great way to test start off is just to do a straight leg raise and see if they can do that on their own and then against resistance. When you do diagnose these, there's a couple of things to be aware of. So they can be treated non-weight bearing in a knee immobilizer, or TROM, so like a post-surgical brace in a locked and full extension, to basically offload that extensor mechanism and let everything come back together. If there is more than 2 millimeters, so very, very little displacement, it does technically warrant surgery. So looking back at this image here, you can actually, if these injuries occur, what can happen is the space between the avulsed portion and the bone can actually fill in with more bone, and actually changes the overall structure of the patella, which then can mechanically change the way that the patella functions, and also tracks within the femoral groove. So it can be very a big problem for people later in life if not treated. Now, again, got to differentiate this between Syndig-Larsen-Johansson syndrome or disease, which can appear similar on X-ray, but is a totally different situation where where that represents an apophysitis of the inferior pole of the patella, and has an insidious onset, not usually some sort of major mechanism. So again, the prompt here described a pretty forceful mechanism in extension with an extended force with extension that leads to these types of injuries. So a good one to know about, not just for the CAQ, but also when you're in your practice. So question number 15, and this is going to be sort of wrapping it up here pretty soon, but the next two questions go together. So the question number 15, a 22-year-old male soccer player comes to see you in training room with lateral foot pain. X-rays are shown below. What is the diagnosis? Is it A, Jones fracture, B, Iceland disease, C, pseudo-Jones fracture, or D, osperineum? So this is a Jones fracture. So these, I think these are they're tough. In some of these can be like borderline, and you're always sort of questioning, where is that line between something like a pseudo Jones or type 1 fracture versus a Jones fracture, a type 2 fracture. Hopefully on the exam, the CAQ, they're pretty good about making them, obvious in terms of their location. But in practice, they can be harder to interpret sometimes. Though the more you see these, the more you're going to get comfortable with it. Again, this is partly why I think this style of questioning is important as you sort of transition away from fellowship, because in fellowship you're getting a chance to look at X-rays with the assistance of other people around or the follow-up of a radiologist. But this is kind of your first time getting a chance to start getting put to the test with a patient in front of you in the form of an actual clinical scenario here. So this technically represents a Jones fracture, and we'll talk a little bit more here, but we'll ask one more question. So this is the same sort of scenario. A 22-year-old male soccer player comes to you in the training room with lateral foot pain. You diagnosed a non-displaced fracture of the proximal fifth metatarsal. Which fracture location has the highest risk of non-union? Is it A, the diaphysis, B, the metaphyseal-diaphyseal junction, C, the metaphysis, or D, the proximal tubercle? So this is another a great sort of example of the types of questions. So like you might know what a Jones fracture is, you might know what it looks like, you might know what how to treat it. The challenge, but you have to have the terminology as well. And so technically, where is the highest risk of non-union? It's in that metaphyseal-diaphyseal junction, which when describing a Jones fracture, we frequently talk about those different zones in the proximal fifth metatarsal. I apologize. I meant to put a picture of that in here, but I have this picture here, which I think is important to remember. So we can use the side of this picture, the adult portion, to sort of think about those typical sort of fractures that we see that we have to classify. So the metaphyseal-diaphyseal junction is that watershed area. So that's that zone 2 or that Jones area, where Jones fracture area, where there's a poor blood supply that puts fractures in that area at higher risk for non-union. Now, if you look at the non-union rates, they're not, it's not like you're guaranteed a non-union, but they're pretty high. I think it's somewhere around 30, 35%. And so again, it's always a question of operative fixation at that point. for our very competitive athletes, even non-displaced fractures in that metaphyseal diaphyseal junction area can be or are frequently treated with operative fixation to ensure no further displacement and healing, appropriate healing in that bony region. So again, this is just an example of the types of questions, especially related to. I think I felt like most of the time related to X-rays. They can be frustrating questions because you can feel like the answer and you're just missing one piece of it. But again, sort of refreshing yourself on the basics of anatomy and some of the interpretation of these radiographs can be incredibly helpful. But that's all I have for us today. So I think we'll wrap up here. I'm sorry. I wish I had put a couple more in. I thought I was going to run too late. I thought I
Adam,
was going to run out of time.
Adam, before you wrap up, Dr. Misra is asking if we could just go through the pathology and the fracture of question 8, if you don't mind. Yeah, and I think to me, you can see on this that there's an area in the inferior aspect of the femoral neck there that appears to have a fracture line.
Yeah,
I
I
don't
just
know
want
if
to
you've
make sure that's what it was. I see it. I just want to make sure I got the inferior side and to understand the ramification as opposed to superior side.
Yeah. So, and actually to your point, so these, so some of the skin folds that actually can play a factor in sort of your visualization of some of these things. So you can see this patient actually does have a skin fold that sort of is moving in that trajectory over that femoral neck. So you really do have to take a really close look at that femoral neck. And you're not getting a chance to actually examine the patients in these scenarios. You'd still do things like a hop test in clinic and get more information. But this is one of those ones that you're always looking for in this sort of clinical scenario, that long distance runner, potentially some energy deficiency, or you're always looking for energy deficiency potentially. But yeah, the compression versus tension sided fractures are treated differently. Now, I didn't go into the extension of some of these fractures. So the percentage of the extension through that femoral neck does make a difference. So even a compression sided femoral neck stress fracture that extends beyond 50% of the femoral neck width can be treated potentially surgically. So ultimately these are not hard fast rules, but generalizations to the typical type of patients that we'll see. So whenever you have any sort of concern or question as to whether or not in your future practice, whether or not hey, is this something I can treat non-surgically, or if you want someone to take another look at it, I'll tell you, I don't hesitate to reach out to colleagues and our surgical teams here to just make sure that I'm not missing something. I will tell you, I immediately reached out to our pediatric orthopedic team when I had that patellar sleeve fracture, because I had just never seen one before, and it's just good to get an understanding that your thought processing is the same as what everyone else is sort of recommending for these types of things. Even if you feel like you have a good sense of things, it's not a bad idea when you're seeing something maybe for the first time.
I would say that goes for your first 5 years in practice. Have a colleague that you can show images to and compare notes, because when you're doing this for the first time and you're seeing injuries for the first time, it's intimidating if you don't have someone to review with. Adam, there was also a question about the Jones fracture, if you don't mind
Yeah.
going back to question 15 and actually just pointing out the X-ray, where the metaphysis and the diaphysis junction
Yeah.
is.
So, the best way to do this, I have found, is if you look at, if you can look, so I'm going to use my pointer here. I hope you guys can see this. So, if you use basically the turning point, so the most medial articulation of, so basically the fifth metatarsal articulating with the cuboid here, that most medial portion here, and you've sort of seen that turn in the bone there. You can use that as your line. sort of your line of demarcation to sort of draw all the way across to the other side, usually where the bone is sort of also sort of turning, curving towards the distal portion of the metatarsal. So this is just within, technically just within that area of that metaphyseal diaphyseal junction. The portion just below that, is considered the epiphysis, and oftentimes referred to as the tubercle. So any fractures really down in this general area are still considered zone 1. So that's pseudo Jones type fracture. Once you move basically beyond basically the articulation of the 5th and 4th metatarsal, so right around this general area, I would draw a line right about here. That becomes the diaphysis beyond that point. So you're looking at from about this point to about this point, anything within here would be considered in that metaphyseal diaphyseal junction, and would be considered that zone 2 area, that watershed area that would make this a Jones fracture and higher risk for non-union, which again, is about 35% risk of non-union in that area.
Very good, Adam. Lots of comments in the chat just thanking you for an excellent review session, which I entirely agree with. I think that was very comprehensive and really good preparation for those of you planning on sitting your boards in the next month. So well done. And that is the last session for the year. So there is a sports economics webinar on Wednesday that Andy has highlighted, and maybe join us then for another session. But otherwise, good luck, everybody. And thank you, Adam. That was really an excellent review today.